in this conference.
Hi, this is Yuko, and we are on lecture number 8. We're going to cover abuse and violence. So abuse is defined as being the wrongful use of maltreatment of another. The perpetrator oftentimes knows the individual who's being abused, and victims are across the lifespan. It's an equal opportunity issue. Types of injuries can be physical, psychological, and the effects on survivors can go on for a lifetime. So violent families, oftentimes spouse battering, neglect, both physically, emotional, or sexual abuse of children, elder abuse, marital rape, common characteristics, social isolation. The perpetrator often has abuse, power, and control. They may also be self-medicating with alcohol and drugs, and oftentimes it's intergenerational. In other words, the process continues throughout the life cycle of several generations. Usually battered individuals grow up to be batterers themselves. Culturally, we know, again, it is an equal opportunity issue. Some countries see women as being their property or the property of the husband or chattel, and oftentimes they have the right to be able to physically reprimand their wife. That's how we got the rule of thumb saying back in Puritan days, a man had the right to beat his wife with a stick that was no wider than the circumference of his thumb. So unfortunately, when certain cultures come over here to the U.S. and they do what is culturally accepted in their country, they oftentimes face legal problems because, of course, it's not legal here. So intimate partner violence, usually misuse or mistreatment of one person. It can be emotional, can be physical, it can be sexual. Occurs more amongst women. Increased rates during pregnancy really makes the individual who's pregnant very vulnerable. And domestic violence and same-sex relationships has the same stats, but the victims have fewer protections. And I want you to think about this. Let's say that there's a partnership going on between two men, and one of the men is 5'3" and the other partner is 6'1", and the 5'3" partner is abusing the 6'1" partner. Do you think that when the 6'1" partner goes to the hospital, that there aren't going to be snide comments made, and possibly even he may end up being laughed at, and that then closes the door for them to want to seek treatment because they get re-victimized all over again? So the clinical picture: abuse is often perpetrated by the husband against the wife. Oftentimes he sees the wife as belonging to him. He has feelings of inadequacy, low self-esteem, very poor problem solving and social skills. So there's increased violence, abuse, and signs of independence. Within these signs of independence, dependency trait is most commonly found in abused women who stay with their spouses. And that could be because oftentimes there's an indoctrination by the partner that tells her that she's lucky that they're together, nobody else would want her, she's ugly, and so forth. All right, so the cycle of abuse, the violence hits, then they go through a honeymoon period where the perpetrator is, I'm sorry, I didn't mean to do it, or if you had made dinner for me in time, I wouldn't have had to hit you, and so forth. Then they begin the tension building phase where she's starting to walk on eggshells and is very careful not to anger her partner, and then all of a sudden the violent acting out. Or victims usually do not seek direct help for the abuse because they oftentimes have been told that if they turn their partner in, that they're going to come after them and kill them, or they use a proxy that they're going to kill the children or even the family pet. Oftentimes, the victims are seen in emergency room settings for different issues other than their domestic violence. They may come in because their stomach hurts, because they're not able to sleep. They have vague somatic complaints. Ask all the patients if they feel safe. You all should be doing a domestic violence screening, and that's why I asked you for this chapter to do one of those screenings as part of your classwork. The key thing is to get the individual alone without the partner, and that may be a very difficult task to complete. You may have to have security remove them from the premises so that you can speak openly and freely to the victim, but oftentimes realize that the victim may not say anything because they're afraid, especially if they're very dependent upon the perpetrator, or if they're holding their children hostage. They can get a restraining order, protection order. The good thing about Tucson is we do have shelters that are anonymous, and the victims can go to those shelters and they can do a video court so that they don't have to appear in court with the perpetrator. And that helps to diminish the fear and also increase their safety. So we need to teach the individuals about the symptoms of a stalker and what the conditions are that warrant being stalked, and also put them into therapy, most certainly themselves and also their children, and get them treated for PTSD, because it's very difficult for the children to experience. And oftentimes, if a male child is in the household, he learns what the role of the male is, and female child learns what the role of a female is, and oftentimes they continue to perpetuate the cycle. So maltreatment of older adults, again, same thing. Oftentimes sexual exploitation is a big one. Neglect is often a big one. Medical treatment, a denial of medical treatment. It's estimated that 10% of the population over 65 are abused by their caregivers. And 60 to 65% of those victims tend to be female. So, unfortunately, a lot of elders depend upon their caregivers, and because they're afraid to lose them, will do anything they can to keep them. A lot of cases are when one older spouse is taking care of another. Oftentimes, bullying occurs in long-term facilities, and the elders are reluctant to report the abuse because they don't want to lose their support and they want to be able to protect them. So we need to be able to look at what's the treatment and intervention? How can we provide the caregiver with stress relief? And that's going to be through the respite services. We can provide other services such as home health. We can get home health aides in there to help bathe the patient, do their laundry, light housekeeping, take care of the patient, and give the caregiver time to be able to take a break and take a nap, take a shower uninterrupted, be able to go out to a movie or go out to dinner. But we do need to be able to take care of the caregiver as well. And in some cases, it may be significant enough where we do have to remove the patient. So school violence, we've heard a lot about that. Bullying is a big problem, especially over the internet nowadays, because it can be done anonymously. And unfortunately, adolescents, teenagers tend to take all this to heart. So I encourage those of you who have children at home to limit their accessibility to the internet and to monitor the internet use, especially what's going on with friends and their comments. We know that oftentimes too, violence on a larger scale, like in communities, often produces PTSD and depression. All right, so hold on and I'll switch. Let's talk about the grieving process. All right, excuse me. All right, so the bereavement process, here's your objectives. So loss is considered the experience or separation from something of personal importance. It can be anything. It can be a person or pet. It can be debilitating conditions, maturational changes such as going to school or starting school, decrease in self-esteem, personal possessions. And that would be in the case of something that's pretty traumatic and uncontrolled, such as hurricanes, earthquakes, and so forth. So Elizabeth Kubler-Ross was the big guru about grieving, and she said there were 5 stages, and that we often bounced between the stages. We did not necessarily move through all the stages sequentially, but we could stay stuck in denial and perhaps the bargaining stage or the anger stage and depression. But she said the ultimate of having resolution to your grief was the stage of acceptance. So we know that oftentimes that acute grief lasts approximately 6 to 8 weeks, but it is very individual and it can last several years. The grief response can be more difficult if there was a strong dependence on the individual specifically that was lost, or if there was an ambivalent relationship, or the individual experienced a recent number of losses. So it can also be more difficult if the relationship was ambivalent. If the loss was that of a young person, because there's no way you can ever rationalize the loss of somebody young. So the person's health was unstable, or if the bereaved person perceives some responsibility for the loss. An example of this would be you and your friend go out driving or go out drinking one night. You're driving while you're intoxicated, you hit a tree and you kill your best friend. Okay? We know that the grieving process can be facilitated or moved through in a better fashion if there's a lot of support for the individual who's doing the grieving. Anticipatory grieving takes place where you know perhaps your work is facing financial difficulties and their plan is to lay off workers, and you know that you're going to be laid off. All right, so make sure you remember the maladaptive responses to loss. Delayed or inhibited grief is the absence of grief when you normally would expect it. It can be pathological because the person is not dealing with the reality of the loss. They remain fixated in the denial stage of the grieving process. And the grief process can be triggered later in a response to a subsequent loss. Distorted or exaggerated grief, normal grieving, has all the symptoms of normal grieving, but they become incapable of managing their ADLs. They remain fixated in the anger stage of the grieving process, and oftentimes they start to get depressed. Chronic or prolonged grieving is where they do things to try to keep the lost one alive. An example would be I have a patient who goes in every night and puts clean pajamas on her husband's bed and turns down his bed, even though he's been dead for over 10 years. Another patient sets a dinner plate every night at the table for his wife, and he sits down and has dinner conversation with her, and she has been deceased for quite a while. The crucial difference between normal and maladaptive grieving is oftentimes there's a loss of self-esteem and depression occurs. So elderly adults oftentimes may get bereavement overload because if they live long enough, they can begin to see their friends die off and they can actually lose family members. I had a patient who was 101 years old who had outlived everybody in his family. He had outlived his spouse and all of his children. Hospice, what a wonderful thing hospice care is. It takes a very special person to do it. There are nurses, everybody on call 24 hours a day. And what I really do appreciate is not only do they help the patient to be able to transition, but they also help with patient pain and symptom management to try to keep them as comfortable as possible. It used to be when a patient was put into hospice, it was because they had 6 months or less to live. Nowadays, that's not always true. It may be because we need tighter pain and symptom management for the patient. The emotional support is phenomenal. It goes on for approximately 6 months after their loved one has transitioned. There are therapists, there are counselors, there are clergy who are available to talk to the family 24 hours a day for 6 months afterwards. So staff support is phenomenal, 24-hour on-call care. What I like is that you can call and perhaps you need a hospital bed. Under a normal Medicare situation, that could take about 2 to 3 months to get, whereupon in hospice, it can take a matter of hours. So let's talk about advance directives. It's a living will or durable power of attorney for healthcare and allows the individual to provide directions about what they want done or not want done should they become incapacitated. Advance directives are usually followed if they are clear. If they are ambiguous and unclear, then they do not need to be followed. What you need to know is that they may be overridden by first-line relatives, that is, a spouse or children. So the proxy, the person who's appointed to make those decisions, may be unsure as to what the patient wants, or the advance directives may not be available at the time that the order needs to be written or the care needs to be provided. So again, it spares the patient's family from having to bear the burden of making the choices for the client. So that's it for that one. Let's move on to eating disorders. Yeah. All right. So there's your lecture objectives. So the hypothalamus is the part of your brain that controls your appetite. Okay. Remember that serotonin rises when you're full, hence it's called the satiety hormone. So we know that biologically there's a genetic vulnerability. There's disruptions in the nuclei of the hypothalamus that relates to hunger and satiety. We know that norepinephrine and serotonin undergo changes, and we don't know if those changes are the result of eating disorders. Are they neurochemically based, or is it the chicken versus the egg? So think about how our society influences our eating behaviors, okay? How many of you in class, when you want to celebrate something, go out to eat? All right, quite a few of us, right? But I want you to look at the culture. What we are looking at is we want people to be thinner, we want them to be healthier, we want them to eat healthier. And then I want you to think about the media and the influence of the media, especially with adolescents. We see Photoshop pictures of celebrities with perfect bodies, perfect shapes, and that's what our adolescents want to emulate. That's a pretty high bar to set for these kids. Is it very realistic? No, it's not. So our culture has definitely influenced what is considered desirable for the female body. Developmental factors, oftentimes the child or the adolescent is struggling for autonomy and identity. They think about what goes on in the typical home. How much autonomy does a child have in a home? They are told what to do, how to do it, when to do it. The only time they can do anything that they are under control of is what they put in their mouth and what they do in school. All right, so the families may be very overprotective or very enmeshed, where they are guiding every move, every thought that the child makes. Body image disturbance is a big issue, especially among adolescents, right? And then looking at themselves and comparing themselves to other teens or celebrities who have these perfect bodies can be very difficult for them. Family influences, think about the dysfunction that goes on. How many of us inadvertently may reinforce weight issues with our children? I remember my daughter is one of those young ladies who has very big hips. And when she was a teenager, um, I remember she was sitting eating some ice cream, and her dad walked by and said, um, your butt is as big as a soccer field as it is, and now you're going to eat this ice cream and you're going to add to it. So, that's most certainly not a very nice thing to say. And then again, social cultural, think about the media and the pressure from others, especially peer pressure. So 30 million people of all ages and genders suffer from an eating disorder. Every 62 minutes, at least one person dies as a direct from an eating disorder. From now on, I'm going to refer to eating disorder as ED. Okay, so EDs have the highest mortality rate. 13% of women over 50 engage in ED behaviors. Active duty military, 5.5% of women, 4% of men had an eating disorder at the beginning of the study, and within just a few years of continued service, 3.3% more women and 2.6 more men developed an eating disorder. The thing you need to realize, right, in the military is everything is governed by your weight. You have to be able to pass physical taping or weight norms. If you don't, then you get put on the fat girl program or the fat boy program, and that can actually result in your discharge from the military. So people with eating disorders have cognitive distortions that are a result of processing errors in the brain. So what that says basically is like when you go to the fair, let's say you're really thin and you go to the fair and you go to the fun house and you look in that mirror where it distorts you, it makes you look really big. That's what their brain is doing. That's the cognitive distortion that they experience. All right. So what we need to look at is how that affects the individual. Underlying those emotions and eating disorders, anxiety, dysphoria, low self-esteem, and feelings of lack of control. So, neurologic, neuroendocrine, and neurobiologic, the chicken and the egg, okay? Genetic models, we know that female relatives of people with eating disorders are up to 12 times more likely to develop them themselves. So we know, again, individuals with eating disorders usually have low self-esteem and have self-doubts about their personal worth. Family theorists believe that dynamics can create eating disorders such as anger issues that may result from sexual molestation, also abuse, and that the Academy for Eating Disorders opposes that theory and says that family dynamics are the primary causes for eating disorders. So prevalence of anorexia, men 0.3%, although that statistic is climbing, and women 1%. Bulimia 1.5% in women and 0.5% in men. Okay, male and female athletes have a higher incidence of eating disorders because they are in a field where weight is significant, right? Other occupations, dancing, models. So they are culturally influenced. There's an increased prevalence in industrialized countries, most common in the US, Japan, New Zealand, Africa, less equal among equal among Hispanic Caucasian women, less common among African American women and Asian women that are born here in the States. Okay, so anorexia appears in middle adolescence. It is a lifelong struggle, all right? It does not just magically go away over a period of time. Anorexia onset usually between the ages of 14 and 18. They tend to be perfectionistic and eager to please. Very, very limited insight, poor judgment about their health status. They tend to be very slow moving, lethargic, and emaciated. Oftentimes they're resistant. They have a terror of gaining weight. They are preoccupied with view self as fat, even when they're emaciated. And they do things like push their food around on the plate. They maintain a rigorous exercise regimen. You do not want to encourage exercise with eating disorders because they're not only going to do 100 push-ups, they're going to do 1,000. And they're going to do it in a clandestine manner, perhaps in the closet or in the middle of the night, but they carry exercise to the nth degree. All right, so 1 in 5 anorexia deaths is by suicide. All right, 50 to 80% is the risk for anorexia and bulimia. That's genetically inclined. All right, half of anorexia patients have a comorbid anxiety disorder, including obsessive compulsive disorder and social phobia. All right, so what do? If we have to, we put them in the hospital, we put NG tubes down them, and we feed them. We do unannounced weigh-ins, okay? So when you weigh a patient with an eating disorder, you don't tell them when you're going to weigh them. You zero out the scale, you have them step on the scale backwards, then you do their weight and you zero out the scale before they get off. You do not at any time discuss the numbers with them because that's what they're going to be focused on. If they keep persisting on knowing what their weight was, refer them to the physician. All right. So you're going to have to do things like give them supplements. You can contract with them that they will eat X amount. Some places have what are called token economies, where they can earn tokens so they can go do things like buy stuff in a commissary or save those tokens to go on trips like maybe Disneyland. You can give them medications, although the medications are not going to be that effective, but only to treat the concurrent anxiety and depression. Most certainly get them into some sort of therapy, either with family and individual therapy, but get them into therapy. So bulimia, opposite. So the thing you need to know about bulimia is that most of the bulimic patients, their weight is close to expected for their weight size, perhaps a little below. They're oftentimes ashamed of their behaviors. They have problems with interpersonal relationships, and initially they can be pleasant and cheerful, but they're going to become depressed. All right. So oftentimes substance abuse is a big issue. What they will do is they will starve themselves all day and then they will binge eat. All right. They will do the self-induced vomiting. They will gag themselves oftentimes with their fingers. So when you're doing your nursing assessment, if you look on the index finger and the middle finger, oftentimes you'll see calluses on the backs of those fingers from sliding against their teeth as they gag themselves. Okay. Oftentimes too, you will find parathyroid stones because of all the vomiting they do. And oftentimes their teeth are also in bad shape from all the acid that they vomit. All right. Usually they will diet and then binge eat and go on another diet. Okay. And so they know that it's pathologic and they will do everything they can to possibly hide it. So what do? We can put them into therapy. We can give them antidepressants. And they also tend to abuse laxatives and diuretics. All right, so the acute phase, get them into an ICU, try to get them to trust you. We talked about the privileges like the token economy. Long-term phase, we want to be able to keep them out of treatment and have them eat healthy. All right, oftentimes what especially the anorexic patient will do is there's a website called ProAna. And if you go into that website, it gives you ideas about ways to maintain your anorexia, such as eating styrofoam, eating paper, um, putting salt in water and drinking copious amounts of salt because it'll make you retain water and you become edematous and show a false positive weight gain. All right. So we can give them antipsychotic medication. And we want to be able to help them to be able to talk about what's going on with them. One of the most important things with a patient who's bulimic is to find out what their triggers are. All right. With bulimic patients, the one thing we need to really watch for is going to be electrolyte imbalance, specifically hypokalemia. All right. Because of all the vomiting and the diarrhea. Oftentimes, too, with the anorexic patient, because they don't have any body mass, they oftentimes develop lanugo, which is the fine hair that you find on newborn babies when they're born, and oftentimes bradycardia. Postural hypotension is going to be an issue, as is dehydration. So we want to be able to help the patient to get in control of their eating. So what do we do as far as nursing interventions? If a patient has an eating disorder, then they need to remain in full view of the staff at all times from 15 minutes to an hour to make sure they don't go down and purge or get rid of food that they may have stashed on their person. They have to be in full view of the staff at all times. They cannot go to the bathroom during this period of time. Watch them for wandering and going into other patients' bathrooms and using their bathroom to purge. All right, so some pictures about anorexia. This is a French model who actually wound up dying from anorexia. This is also Nolita. She also died from anorexia. I don't know about you guys, but this model looks extremely uncomfortable. You can see the tendons in her legs. Look at her rib cage. I mean, she does not look like she's very healthy. She looks very weak and very fatigued. This is the body dysmorphic disorder. This is what the patient actually looks like, and this is what they see when they look in the mirror. I mean, look at, you can count all of her vertebrae, her ribs. Manorexia, men are being diagnosed with more and more episodes of anorexia. This gentleman here used to look like this. He was absolutely gorgeous, but he wound up dying too from his manorexia. Here he is as a model, and this was him shortly before his death. So, with anorexia, the weight loss is extreme, usually more than 15% of their expected weight. In order to be diagnosed with anorexia per DSM-5, this is what the criteria is. Other symptoms, females have to have missed 3 consecutive menstrual periods, and oftentimes they become obsessed with food. They will have safe foods. Those are foods that are usually determined by texture as to what is safe for them. So they'll eat things like puddings, yogurt, scrambled eggs. So with bulimia, don't forget electrolyte imbalance is a big issue. Okay, so we're going to go to the other end of the spectrum, talk about obesity. This was an interesting study that was done here in Tucson. At a hospital, the nurses and the techs were asked about their feelings in working with bariatric patients. Over 75% of those who were asked said that they felt that bariatric patients smelled and that they were lazy and that they deserved what they got because they were overweight. But how many of those workers who were asked about this were overweight themselves? Okay. Nursing is not known for a bunch of healthy, skinny people. In fact, there's an old saying, the way to a nurse's heart is through her stomach. So physiological, the etiology implications, hypothyroidism, decreased insulin production, hyperlipidemia, osteoarthritis, respiratory insufficiency. Okay, it could be caused because of increased caloric intake, sedentary lifestyle. Unfortunately, nowadays, everything enhances a sedentary lifestyle, right? If we want to go shopping, we can do it on the internet. If we want groceries delivered, all we have to do is get on our phone. We don't have to go out of our house. We can sit on our couch and do everything we need with the use of a computer or a smartphone. We don't have to get up and do much of anything. So psychosocial influences, good old Sigmund Freud, my favorite, Captain Obvious, said that it was because we were fixated in the oral stage of our psychosexual development and there was unresolved dependency needs. So what can we do? We can get them to support services like Weight Watchers International, Overeaters Anonymous, all right? We can do behavior modification, but it's difficult to not only change your diet, but change your entire lifestyle. And oftentimes, if you have a partner who is also overweight, it's going to call for their participation in this, or you're not going to be real successful in it. All right, so again, the behavior modifications, what we need to do is we can do contracting so that the patient can see that they're in control. They're in control by signing the contract. They're in control of what they eat, how much exercise they do, and whether or not to induce their vomiting. We can help them to set goals and also to look at a system of rewards for them. We can give them medications, okay? These medications you guys are already aware of. But we know that there isn't any success medication-wise with eating disorders, only with the concurrent anxiety and depression. All right, so the other medications that we can use. All right, for obesity. All right, and that is it for lecture number 8. All right, thank you for your